Welcome back to the deep dive. Today we are leaving the well-lit paved roads of the microbial city. We aren't talking about the E. colis or the Staph aureus of the world. You know, the ones that have their own dedicated chapters and neatly organized families.
No, today we're heading into the weeds.
Yeah.
Literally and figuratively. We're getting into some of the stranger corners of the microbial world.
I like to call this group the island of misfit toys of the bacterial world. You know that part of the toy store where things don't quite fit the main categories? That's where we are.
It's a perfect analogy. In the academic world, and specifically looking at Murray's Medical Microbiology, Chapter 29, these organisms are kind of unceremoniously dumped into a bucket called miscellaneous gram-negative rods.
Right.
It sounds so dismissive, doesn't it? Like a junk drawer in your kitchen.
It really does. Miscellaneous. It just implies they aren't important, that they're an afterthought. But when you actually open that drawer, you find the Black Death. You find potential biological weapons.
You find bacteria that can turn your liver into Swiss cheese.
Exactly. That is the paradox. They are taxonomically awkward. They don't fit into the Enterobacteriaceae family. They aren't quite Pseudomonas. They aren't quite Haemophilus. But clinically?
Oh, clinically, they are absolute heavy hitters.
Mm-hmm.
And because they are so distinct, they each have a very specific, almost cinematic personality.
That's our mission for this deep dive. We aren't just going to memorize a list of names. We are going to map out this island of misfit toys. We want to understand the unique superpower of each of these organisms. Why do they behave the way they do? What is their evolutionary logic?
And to keep this organized, we're going to follow the structure of Murray's Chapter 29 very strictly, moving alphabetically from Bartonella all the way down to Streptobacillus. But we have to make a pit stop.
The cousins?
The cousins. We're pulling in Yersinia and Pasteurella from the Gelasi's textbook. Even though Murray puts them elsewhere, you cannot understand the zoonotic gram-negative rod landscape without them. They really provide the context that makes the others make sense.
So if you're a medical student listening to this is some seriously high-yield territory for your exams. And if you're just a curious mind, this is a tour of some of the strangest evolutionary strategies on the planet. Let's start with the letter B, Bartonella.
Ah, yes. The vascular gardeners.
I love that title, but it's also, kind of horrifying. When I think of an infection, I think of destruction. Bacteria eating tissue, releasing toxins, killing cells. But Bartonella does something completely different. It builds.
It creates its own habitat. That is the fundamental insight you need for Bartonella. Most bacteria induce this sort of, pyogenic inflammation that destroys tissue. Bartonella produces factors that stimulate endothelial cells, the cells that line your blood vessels, to proliferate.
So it's causing angiogenesis.
Angiogenesis on overdrive.
Yeah.
It's not just a little bit of new blood vessel growth. It's explosive. It's remodeling the host's own tissue to create a perfect blood-rich environment where it can thrive.
Wow. So it's essentially farming the human body.
In a way, yes. It's creating these vascular niches. Now, before we get into the diseases, let's look at the bug itself. It's a small gram-negative rod, often coccobacillary, so kind of short and plump. But if you try to grow it in the lab, you're going to have a bad time.
Because it's fastidious, which is just science speak for high maintenance.
Extremely high maintenance. It grows very, very slowly. We're talking 2 to 6 weeks on a plate. Now think about a clinical lab.
They're not holding plates for 6 weeks.
Never. If a doctor suspects Bartonella and sends a standard culture, the lab is going to look at that plate after 3, maybe 5 days, see nothing, and report no growth. You have to specifically tell them, hey, hold this plate. I suspect the gardener. You have to give them a heads up.
And even just looking at it under a microscope is tricky, right? It's gram-negative, so it should be pink, but it stains poorly.
It barely shows up. It's a very faint pink.
Right.
To really visualize it in a tissue sample, you need a special stain. And this is a huge one for exams.
The Warthin-Starry silver stain.
The Warthin-Starry. I want to just park on that for a second.
Yeah.
If you see that phrase on an exam or in a pathology report, your brain should immediately flash a giant neon sign that says Bartonella. Or, to be fair, maybe syphilis. But in this context, Bartonella.
What does it look like?
It uses a silver impregnation method. So the bacteria take up the silver and they appear black against a yellow or brownish background. It's very, very distinct.
Okay, so a slow-growing, poorly staining rod that needs a silver stain to be seen. Got it. Now, within this genus, you mentioned a triad of species that cause human disease.
Yes, and they're great because they are so geographically and clinically distinct. It makes them easy to keep separate in your mind.
Let's start with the one that sounds like an explorer. Bartonella bacilliformis.
This is the Andes specialist.
Mm-hmm.
This organism is a perfect lesson in medical ecology. It is entirely restricted to the Andes Mountains. We're talking Peru, Ecuador, Colombia.
Why, though? Is the bacteria afraid of sea level or something?
The bacteria is probably willing to travel, but its Uber driver is not. The vector is the sandfly, specifically the genus Phlebogamous. This particular sandfly only survives at certain altitudes, usually between 2,000 and 3,000 meters in the Andes.
So no sandfly, no transmission.
No sandfly, no transmission. It's a beautifully contained ecosystem. So if a patient presents with these symptoms in, say, New York and hasn't traveled, you can cross this off the list immediately. But if they've been trekking in Peru, you have to consider it.
And if they have it, they might get a biphasic disease, 2 phases.
And the phases are radically different from each other. This is one of the weirdest things in microbiology. Phase 1 is called Arroyo fever. This is the acute phase.
Okay.
The sandfly bites you, the bacteria enter the bloodstream, and they do something incredibly aggressive.
Yeah.
They invade the red blood cells.
They go inside the erythrocytes. That's unusual for a bacterium.
It's very unusual. They use these polar flagella to attach, and then they just push their way into the red blood cell. And once inside, they replicate, which weakens the cell membrane and tags it for destruction by the spleen, leading to massive hemolysis. The cells just burst.
So the patient crashes hard.
Crashes very hard. Severe hemolytic anemia, fevers, pallor, weakness, jaundice. Historically, before antibiotics, the mortality rate for Arroyo fever was terrifying, up to 40% or even as high as 80% in some outbreaks. It's a devastating acute illness.
But let's say you survive. You get through the anemia, you get treatment, you think you're in the clear. Then comes phase 2.
Months later, the gardener wakes up. This is Verruga peruana, or the Peruvian wart. The bacteria, having survived the acute phase, move from the blood into the skin and start stimulating that angiogenesis we talked about.
So they switch from destroying blood vessels to building them.
Exactly. It's an incredible pivot. And you get these nodular red-purple, blood-filled skin lesions. They can be a few millimeters to a couple of centimeters. They look like warts. But if you poke one, it bleeds profusely because it's just a tangle of new blood vessels.
So a biphasic illness, one that destroys blood and one that builds blood vessels, all from the same bug.
All from the same bug. It's a wild duality.
All right, let's move from the Andes to the trenches of World War I, Bartonella quintana.
The agent of trench fever. This one has a much less picky vector. During the First World War, over 1 million soldiers were infected. The vector here isn't a high-altitude sandfly. It's the human body louse.
Which thrives in crowded, unhygienic conditions.
Exactly. Trenches, refugee camps, and unfortunately today, in populations experiencing homelessness, we still see what we call urban trench fever in inner cities among individuals with poor hygiene.
And the symptoms are miserable. I've read they call it shin bone fever.
Because the bone pain, especially in the shins, is excruciating. It's one of the defining features. But the fever is also unique. It's called 5-day fever, or Quintana fever, because it tends to relapse.
How so?
You'll have a high fever for a few days, it'll break, you'll feel better, and then 5 days later, boom, it's back with a vengeance. The bacteria are cycling in the blood, causing these periodic episodes of fever and pain.
But here's where we need to connect the dots to modern medicine, right? In the 1980s, during the HIV/AIDS epidemic, doctors started seeing something new involving Bartonella quintana.
This is the critical link to immunocompromise. In a healthy person, B. quintana causes that fever and bone pain. But in an AIDS patient with a very low CD4 count, the bacteria run wild with their vascular gardening skills. They cause a condition called bacillary angiomatosis.
Break that down for us. Angiomatosis meaning too many vessels.
Correct. The patient develops these purple vascular nodules all over their skin. They look like little berries made of blood. And they can also grow in internal organs, liver, spleen, bone.
Now, if I'm an infectious disease doctor in the 80s or 90s and I see an HIV patient with purple skin nodules, my first thought isn't Bartonella, it's cancer.
Right. Your first, second, and third thought is Kaposi sarcoma, which is caused by a virus, human herpes virus 8. Macroscopically, just by looking at them, they can be identical. You cannot tell them apart.
So you absolutely have to do a biopsy, and this is the critical differentiator. What are we looking for under the microscope?
You are looking for the type of inflammatory infiltrate. Kaposi sarcoma is a tumor driven by a virus, so the immune response you see is primarily lymphocytes and spindle cells. Bacillary angiomatosis, on the other hand, is a bacterial infection. Even though the immune system is weak, it still tries to send in the infantry.
And the infantry for bacteria is neutrophils.
Neutrophils. So if you see a proliferation of blood vessels surrounded by a sea of neutrophils, you are looking at bacillary angiomatosis. Neutrophils equals bacteria equals Bartonella.
And I bet if you threw that special stain on the slide...
If you do a Warthin-Starry silver stain on that biopsy, the Bartonella will light up as little black rods cluster together. Kaposi sarcoma will be negative. It's a definitive test.
That's a fantastic clinical pearl. That brings us to the third and probably most common member of the family, Bartonella henselae, the feline connection.
Cat scratch disease. This is the one most listeners might actually encounter, in their own lives or in a general pediatric clinic. The reservoir is the domestic cat, and specifically kittens.
Wait, kittens? Are they just, dirtier?
They just have higher rates of bacteremia. The cat carries the bacteria in its blood but doesn't get sick. It's the perfect asymptomatic reservoir. The vector that passes it between cats is the cat flea, but the transmission to humans is usually a scratch or a bite.
Or, and this is kind of gross, flea feces getting into a wound.
Yes, that's a major route. The flea bites the cat, gets the bacteria, then defecates on the cat's fur. When the cat scratches you, it inoculates that flea dirt, which is teeming with Bartonella, directly into your skin.
Okay, so what's the classic clinical picture? I'm playing with a kitten, I get a little scratch on my arm. A few weeks later, what happens?
You've likely forgotten all about the scratch. But then you notice a little bump, a papule or a pustule right where the scratch was. And then, the key finding, the lymph nodes that drain that area start to swell up.
So if I was scratched on the hand?
Your armpit, the axillary lymph nodes, or the one by your elbow, the epitrochlear node, will get huge and tender. It's a classic regional lymphadenopathy. The infection travels up the lymphatic highway and gets stuck at the first toll booth.
And usually if you have a healthy immune system, that's pretty much it, right?
For most people, yes. It hurts. You might have a low-grade fever. You feel crummy for a week or two, but it resolves on its own. It's self-limited.
But if we go back to our immunocompromised patient...
Then Bartonella henselae acts just like Cantana. It can absolutely cause bacillary angiomatosis, and it has a special trick up its sleeve. It has a particular affinity for the liver. It causes a condition called paliosis hepatis.
Which sounds like a spell from Harry Potter.
It does. But it just describes blood-filled cysts or lakes in the liver. If you do a CT scan of the liver, it looks like a sponge that's been soaked in blood. It's the same vascular gardening mechanism, just happening in a different organ.
So to treat these gardeners, whether it's henselae or Cantana or bacilliformis, you need something that gets inside the tissue and, importantly, inside the cells.
Exactly. Since it can hide intracellularly, especially within endothelial cells, things like penicillins aren't great. You reach for macrolides like azithromycin or tetracyclines like doxycycline. You need an antibiotic that can get in there and weed the garden, so to speak.
All right, let's leave the vascular garden and move to the airway. Next letter up. B. Bordetella.
Specifically Boradipal pertussis, the agent of whooping cough.
I call this one the cilia paralyzer.
That's a very good functional name. This is a tiny gram-negative coccobacillus. And unlike Bartonella, which gets into the blood, Bordetella is a surface dweller. It is a strict aerobe, and it lives exclusively on the ciliated respiratory epithelium. It doesn't invade.
I always picture this one having like Velcro shoes. It just sticks to the surface of the airway.
That's the adhesion phase, and it's a great analogy. It has these critical virulence factors, proteins like filamentous hemagglutinin or FHA and pertactin. These proteins bind with incredible specificity to the cilia of the cells lining your trachea and bronchi.
So it latches on tight.
Yeah.
But it doesn't actually invade the tissue or enter the blood.
No, it's a non-invasive pathogen. It just sits on that luminal surface of the windpipe and starts producing a whole arsenal of toxins. And this is where the paralyzer name really comes in. One of the most important local toxins is called tracheal cytotoxin.
And what does that do?
It's a piece of its own peptidoglycan cell wall that it sheds. And this molecule is directly toxic to ciliated epithelial cells. At low concentrations, it causes ciliostasis. It paralyzes the cilia. At high concentrations, it kills them outright.
So it stops the mucociliary escalator.
It completely destroys the mucociliary escalator. Normally, your airway has these millions of tiny hairs, the cilia, that beat in a coordinated rhythm to sweep mucus, dust, and debris up and out of your lungs. Tracheal cytotoxin stops that movement and then kills the cells responsible.
So you're left with all this gunk in your lungs.
All this mucus, dead cells, and bacteria are accumulating down in your lungs. You can't sweep it out. The only way left to clear it is to cough violently.
That explains the sheer violence of the cough. It's a desperate mechanical compensation for a broken biological system.
Exactly. But Bordetella has another weapon, a systemic weapon that causes effects far beyond the lungs, the famous pertussis toxin. This is a classic AB toxin, and the mechanism is a board exam favorite.
Walk us through the biochemistry. It involves the G proteins, right?
Right. Our cells use G proteins for all kinds of signaling. There's GNAS, which is stimulatory, and GI, which is inhibitory. Pertussis toxin specifically targets the G protein. It chemically modifies it through a process called ADP ribosylation.
And what does that do to the inhibitory protein?
It disables it. Think of the G protein as the brakes for an enzyme called adenylate cyclase. If you cut the brake line, the car speeds up uncontrollably. Without G's inhibition, adenylate cyclase goes wild, producing massive amounts of cyclic AMP, or MAKE-AMP.
And what is the clinical result of all that extra KMP?
Well, in the respiratory tract, it leads to a huge outpouring of fluid and mucus, contributing to that awful cough. But the most unique and diagnostically important effect happens in the blood. This toxin confuses the signaling of lymphocytes.
How does it do that?
Normally, lymphocytes patrol the blood, and then when they get a signal, they exit into the tissue or lymph nodes to fight an infection. The pertussis toxin, by messing with the G protein, essentially disables the chemokine receptors that act as the lymphocytes' exit signs.
So they get trapped on the highway. They can't get off at their exit.
Exactly. They're stuck in the bloodstream, driving around in circles. So unlike most bacterial infections where you see a neutrophilia, high neutrophil count, in pertussis you see a massive lymphocytosis.
That is a huge red flag. A kid with a violent cough and a white blood cell count of 30,000 or 50,000, and it's all lymphocytes.
You might think it's leukemia. You might think it's a bizarre viral infection. But if they have that cough, it is pertussis until proven otherwise. The lymphocytosis is pathognomonic.
Let's talk about the cough itself, the infamous 100-day cough, the stages.
There are 3 classic stages. Stage 1 is the catarrhal stage. This lasts for about 1 to 2 weeks. The patient has a runny nose, sneezing, maybe a low-grade fever.
That looks exactly like a common cold.
It is indistinguishable from a cold. And this is the tragedy of pertussis. This is the stage where the patient is most infectious. They're shedding huge numbers of bacteria. But it's also the stage where it is almost never diagnosed because it seems so mild and nonspecific.
Then comes stage 2, the paroxysmal stage.
Now, the toxins have done their damage. The cilia are gone, the mucus is thick, and the patient has these fits, these paroxysms of rapid consecutive coughs. They might cough 15, 20 times in a row without taking a breath.
They're literally suffocating.
Yes. They are coughing all the air out of their lungs. At the end of the fit, they take a desperate, massive inhalation through a still narrowed glottis.
And that creates the whoop.
That high-pitched inspiratory stridor. Whoop, whoop. And the force of the coughing is so violent, it often triggers the gag reflex.
Yeah.
So you see posters of vomiting. That's another classic sign.
If a parent tells you their child coughs until they throw up, that should set off alarm bells for pertussis.
Absolutely. Then finally, if they get through that, stage 3 is the convalescent stage. This is the 100-day part. The bacteria are probably gone, but the physical damage to the respiratory lining takes weeks or even months to heal. The cough just lingers and lingers.
Diagnosis here requires special handling too, right? You can't just use a regular cotton swab.
No, absolutely not. Cotton fibers actually contain fatty acids that are toxic to Bordetella. It's that sensitive. You need a calcium alginate or a Dacron swab. And you need to send it on special transport media to the lab where they plate it on our media matches.
The special menu for Bordetella?
Regan low medium, which has charcoal and blood, or the classic Bordecango agar, which has potato, glycerol, and blood.
Charcoal. Why charcoal?
Same principle as a stomach pump, really. The charcoal absorbs toxic substances in the agar-like fatty acids or peroxides that would otherwise inhibit the bacteria's growth. It acts as a detoxifier to let the very shy, very picky bacteria grow.
Got it. Charcoal for the cilia paralyzer. Prevention is obviously key with the vaccine, DTaP and Tdap, but let's move to our next B. brucella.
The unpasteurized undulator.
This one feels like we're taking a trip to a farm. We have 4 main species, and they each have a favorite animal host.
It is a classic zoonosis, and you can almost map the species to the animal. You have Brucella melitensis from goats and sheep, Brucella abortus from cattle, Brucella sus from pigs, and Brucella canis from dogs.
And it's melitensis, the goat and sheep one, that is the most common cause of human disease worldwide.
And generally the most severe. The transmission to humans is almost always either through consuming unpasteurized dairy products, think fresh goat cheese from a farm, or through occupational exposure, vets, slaughterhouse workers, farmers.
There is a fascinating chemical reason why these bacteria love these specific animals so much. It involves a sugar called erythritol.
Yes, this is a great example of host pathogen specificity. Buchella has a strong preference for erythritol. It uses it as a primary carbon source. Now, in these animals, cattle, goats, pigs, erythritol is found in very high concentrations in the placenta, the breast tissue, and the epididymis.
So the bacteria migrate to the placenta, grow explosively, and cause septic abortion in the animal.
Exactly. It's primarily a reproductive tract infection in animals. That's why one species is named B. abortus. But humans, our placentas do not contain erythritol.
So we don't get the abortions, but we get something else entirely.
Right. When the bacteria enter our body, they're quickly phagocytosed by macrophages. But Brucella is a facultative intracellular parasite. It has mechanisms to survive and replicate inside the macrophage, resisting killing. It basically rides the macrophage like a Trojan horse.
A Trojan horse into which part of the body?
Into the reticuloendothelial system, or RES. So we're talking the liver, the spleen, the lymph nodes, and especially the bone marrow. It sets up these little chronic pockets of infection and forms granulomas.
Small collections of chronic inflammation. Hideouts, basically.
Perfect word for it. They're hideouts. And from these hideouts in the RES, it periodically releases bacteria back into the bloodstream.
And that periodic release is what causes the unique fever pattern.
The undulant fever. It rises and falls like a wave. The fever spikes in the afternoon and evening, often with drenching sweats, and then resolves by morning. This can go on for weeks or months, along with profound fatigue, body aches, and a very specific symptom described in the old textbooks, a moldy or wet hay smell to the sweat.
That is so specific. If a patient smells like a wet barn and has a cycling fever, you should think Brucella.
It should be on your differential, especially with the right exposure history. And because it loves the RES, it loves the bone marrow. It frequently causes osteomyelitis with a particular fondness for the lumbar vertebrae. So a patient with chronic lower back pain and a history of eating unpasteurized goat cheese in Mexico, that's Brucella until proven otherwise.
Treatment has to be tough because it's hiding inside our own cells.
It is. A short course won't work. You need a long course, usually 6 weeks of combination therapy. The classic regimen is doxycycline plus rifampin. You need antibiotics that can penetrate the macrophage and get into that granuloma.
Okay, let's move to letter C, cardiobacterium.
Right. We can keep this one a bit briefer, but it's absolutely vital for anyone on the cardiology service. This is Cardiobacterium hominis, and it's famous for being a member of the HACE group.
HACEK. That's an acronym every medical student has to memorize. HACEK.
Yep. Haemophilus, Aggregatibacter, Cardiobacterium, Legionella, and Kingella. And what do they all have in common?
They're a gang of fastidious, gram-negative bacteria that live harmlessly in our mouth and throat. Normal flora.
Normal flora. And their collective claim to fame is endocarditis.
Specifically, what's often called culture-negative endocarditis.
Right. And it's a bit of a misnomer. It's not that they can't be cultured. It's that they grow so darn slowly.
So walk me through the scenario. A patient with a damaged heart valve, maybe from childhood rheumatic fever or a congenital defect, goes and gets some major dental work done.
Right. That dental work causes a transient bacteremia. These mouth bacteria like cardiobacterium get into the blood, they circulate around, and they see that damaged turbulent surface of the heart valve and think, hey, that looks like a great place to stick. They land on the valve and start a very slow, smoldering infection.
But when you draw blood cultures, nothing grows in the first 48 hours, so the lab reports them as negative.
Exactly. So the clinical team is scratching their heads. The patient has a fever, a new heart murmur, but the cultures are negative. But if you tell the lab to hold those cultures for a week, 2 weeks, even 3 weeks, cardiobacterium will finally show up.
So the lesson is, if you suspect endocarditis but the initial cultures are negative, you have to ask about recent dental history and think HACEK.
It should be at the top of your list.
Okay, moving down the alphabet to section F, Francisella. I call this one the rabbit mower. This is where things get a little cinematic, almost horror movie style.
Francisella tularensis. This is arguably the most dangerous organism on our list today in terms of pure infectivity.
The infectious dose is terrifyingly low.
It is shockingly low. We think it's somewhere around 10 to 50 organisms if inhaled. If you inhale just a handful of bacteria, you can get severe life-threatening disease.
Right.
That is why it's classified as a Category A bioweapon agent alongside things like anthrax and smallpox.
And it poses a huge risk to lab workers.
A massive risk. If a doctor suspects tularemia, they must warn the lab. You write it in big letters on the requisition, rule out tularemia. That tells the lab, do not open this plate on the open bench. If a lab tech takes a whiff of a plate of Francisella, they can get pneumonic tularemia and die. It requires biosafety level 3 containment
Now, why do I call it the rabbit mower?
because of the very specific epidemiology. Francisella infects lagomorphs. Rabbits and hares are the main reservoir in North America. Ticks are a common vector, so one way humans get it is the classic hunter scenario. You kill a rabbit, skin it, and the bacteria enter through a tiny nick in your skin.
But the other way is the suburban nightmare.
The lawnmower scenario. This is a real thing. A landscaper is mowing tall grass, maybe on Martha's Vineyard or in Arkansas. There's a rabbit nest hidden in the grass. The mower goes over the nest.
Oh, man.
It's gruesome, I know. But from a microbiological perspective, that mower blade instantly creates a highly infectious aerosol of blood and tissue containing millions and millions of bacteria. The landscaper breathes in that red mist.
And because the infectious dose is so low.
They develop pneumonic tularemia a few days later. This is the most severe form. Rapid onset fever, chest pain, sepsis. It looks like a severe community-acquired pneumonia, but it progresses incredibly rapidly to respiratory failure and death without the right treatment.
But if you get it from the skinning scenario, the hunter who gets a cut, it looks totally different.
That's the most common form, ulceroglandular tularemia. The bacteria enter the skin. At the site of entry, the skin cells die, creating a painful black-based ulcer called an eschar. Then the bacteria travel up the lymphatics to the nearest lymph node, causing massive, painful swelling or lymphadenopathy. Ulcer plus gland.
And if you just rub your eye after touching the infected rabbit,
That gives you oculoglandular tularemia. You get a painful, purulent conjunctivitis and a swollen lymph node right in front of your ear, the pericular node. That specific combination, a nasty red eye plus a swollen pericular node, is called Perinaud's oculoglandular syndrome, and tularemia is a classic cause.
microbiologically, this bug is also a diva in the lab. It has special needs.
It absolutely does. It requires cysteine. It is a cysteine auxotroph. Standard blood agar doesn't have enough free cysteine for it to grow. So you need to use chocolate agar where the red blood cells are lysed, releasing all their nutrients, or, even better, BCYE agar.
Wait a minute, BCYE, that sounds very familiar.
It should. It's the primary agar for our very next misfit, Legionella.
That's a perfect transition. Let's talk about Legionella pneumophila, the water system lurker.
The story of Legionella is a true medical detective story. It wasn't even discovered until 1976, following a mysterious outbreak at an American Legion convention in Philadelphia. A bunch of mostly older male veterans got a very strange, very deadly pneumonia.
And the CDC eventually traced it to the air conditioning system of the hotel they were staying at.
Right. And this brings us to the Trojan horse concept, which is key to understanding Legionella. In the wild in lakes, streams, puddles, Legionella is an aquatic organism, but it doesn't just float around freely. It gets eaten by amoebae.
Single-celled protozoa that go around hunting bacteria for food.
Exactly. And usually the amoeba eats the bacteria and digests it in a little vacuole. But Legionella has evolved a whole set of virulence factors to survive inside the amoeba. It prevents the digestive enzymes from fusing with its vacuole and turns the amoeba into a nursery where it can replicate safely.
It hacks its own predator.
It completely hacks its predator. Now, fast forward to the hotel's cooling tower. The water system is full of these amoebae, which are full of Legionella. The cooling tower creates a fine mist. The veterans are standing outside. They inhale that mist. The bacteria get deep into their lungs.
And down in the lungs, we have our own amoeba-like cells, the alveolar macrophages.
Which are basically the human version of an amoeba. They're professional phagocytes. The macrophage gobbles up the Legionella thinking it's a snack, and the Legionella bacterium says, hey, I know this place. This looks just like the amoeba I grew up in.
So the same machinery evolved over millions of years to fight amoebae works perfectly against our most important immune cells.
It's a complete evolutionary accident that makes it a perfect human pathogen. It hijacks the macrophage and turns it into a factory for more Legionella.
Clinically, this can cause two distinct diseases, right? Pontiac fever and Legionnaire's disease.
Correct. Pontiac fever is the milder version. It's basically like getting the flu. You inhale the bug, and a day or two later you get fever, chills, muscle aches, headache. But crucially, no pneumonia. It goes away on its own in a few days. It's likely a self-limited hypersensitivity reaction to bacterial toxins without a full-blown infection.
But Legionnaire's disease is the killer.
That's the one we worry about. It's a severe atypical pneumonia. Atypical because the patient can be very sick, but when you listen to their chest with a stethoscope, it can sound surprisingly clear early on. The X-ray, though, looks terrible, often with multilobar consolidation.
And the key to diagnosing it is often looking outside the lungs.
Yes. The extrapulmonary clues are everything for Legionella. We often talk about the classic Legionella triad. Number 1, the pneumonia. Number 2, GI symptoms, specifically watery diarrhea. And number 3, neurologic symptoms, most commonly confusion or delirium.
And there is a classic lab value that often clinches it.
Hyponatremia, low sodium in the blood. The mechanism isn't perfectly clear. It might be related to SIADH, but it's a very common finding. So if you have a confused elderly smoker with pneumonia, diarrhea, and a sodium of 128, that is Legionella until proven otherwise.
Diagnosis. We mentioned the BCYE agar.
Buffered charcoal yeast extract agar. Again, the charcoal detoxifies the agar, and the yeast extract, the Y, provides the two things the bug absolutely needs to grow, iron and L-cysteine. But in the real world, the test we use most often is the urine antigen test.
You just pee in a cup and a quick test tells you if you have Legionella. Seems perfect.
It's fast and it's great. But it has one major limitation. It only detects the antigen for Legionella pneumophila serogroup 1. Now, that serogroup causes about 80% of cases, so it's usually helpful. But if your patient has serogroup 6, the test will be negative. So a negative urine antigen test does not 100% rule out Legionnaire's disease.
And treatment, you can't just use a penicillin, can you?
Absolutely useless, for two reasons. One, Legionella produces beta-lactamase enzymes that chew up penicillins, and more importantly, it's intracellular. You need an antibiotic that can get inside the macrophage. So the drugs of choice are macrolides, like azithromycin, or fluoroquinolones, like levofloxacin.
Okay, let's hit section 7, streptobacillus. The rat bite puffball.
Streptobacillus moniliformis. This is the primary cause of a disease called rat bite fever in North America.
Not to be confused with plague or other rat-associated things. This is from a direct bite.
Right, or scratch. It's a normal part of the oropharyngeal flora of rats, so lab workers, pet store employees, or people living in rat-infested housing are the ones at risk.
So the bite happens, maybe it heals up, but then what?
About 2 to 10 days later, the systemic illness begins, and you get a classic triad: fever, polyarthralgia, and a rash.
Polyarthralgia meaning pain in multiple joints.
And it's typically a migratory polyarthralgia. First your knee hurts, then a day later that feels better but your elbow's killing you, then your wrist. It moves around.
And the rash. What's special about it?
It's often petechial little pinpoint bleeds under the skin or maculopapular. But the key is the location. It frequently involves the palms and soles.
That is a very, very short list in medicine. When you see a rash on the palms and soles, you should think of things like secondary syphilis, Rocky Mountain spotted fever, Coxsackie A virus, and rat bite fever.
It's a critical clue. And a fun microbiology fact. In broth culture, this organism doesn't make the broth cloudy. It grows in little clumps at the bottom that look like puffballs of cotton. And on a regar, it can spontaneously lose its cell wall, becoming something called an L form, and the colonies look like tiny fried eggs.
Puffballs and fried eggs. A very chaotic breakfast. Okay, now let's bring in the heavy hitters from Jawets, the so-called cousins, Yersinia and Pasteurella.
Let's start with the big one, Yersinia pestis, the plague. The Black Death. This single organism has killed more humans than perhaps any other bacterium in history.
Taxonomically, it's actually a member of the Enterobacteriaceae, like E. coli, which is weird to think about. But ecologically, it fits perfectly here because it's a zoonosis.
And under the microscope, it has a classic appearance. With a right or Giemsa stain, it shows bipolar staining. The ends of the rod stain darker than the middle, so it looks like a closed safety pin.
I want to talk about the flea. The transmission mechanism is pure evil genius.
It is fascinatingly cruel. The bacteria possess an enzyme called coagulase. This isn't just a random enzyme. It has a very specific purpose. When a flea bites an infected rat and drinks its blood,
The coagulase clots the blood.
it clots the blood inside the flea's proventriculus, which is basically its foregut. The bacteria then multiply like crazy within that clot, forming a biofilm that completely blocks the flea's digestive tract.
So the flea is starving.
It's starving to death. It can't swallow anything. So it goes into a feeding frenzy. It jumps from host to host, rat to rat, or rat to human biting repeatedly, desperately trying to get a blood meal.
Yeah.
But it can't. So with each bite, it regurgitates the bacteria-laden clot back into the bite wound. The bacteria have literally weaponized their own vector.
That is terrifying. And once it's in the human...
It uses a type 3 secretion system. You can imagine it as a molecular syringe. It injects proteins called YAPs, that stands for Yersinia outer proteins, directly into our macrophages and neutrophils. These YAPs proteins paralyze the phagocyte's ability to send alarm signals and to eat the bacteria. It completely silences the initial immune response.
which allows it to replicate unchecked, resulting in the bubo.
Exactly. Bubonic plague. The bacteria travel to the draining lymph node, and with no immune response to stop them, they replicate to enormous numbers. The lymph node swells massively, becomes filled with blood and pus, and turns black from necrosis. That is the bubo. It's incredibly painful.
And if it gets from the lymph node into the bloodstream and then to the lungs?
Then you get pneumonic plague. And this is the real nightmare scenario, because now the patient can cough and create an infectious aerosol, spreading it directly from person to person. This form is highly contagious and, without treatment, is nearly 100% fatal.
There is another important Yersinia, though. Yersinia enterocolytica, the great mimic.
This one is a whole different ballgame. It's transmitted not by fleas, but by contaminated food or water, classically undercooked pork or contaminated milk, or via pet feces, especially from puppies. And a key feature is that it's cold tolerant. It can actually grow in the refrigerator.
And it's famous for causing pseudoappendicitis.
It has a predilection for invading the Peyer's patches in the terminal ileum and the mesenteric lymph nodes, which are located right next to the appendix in the right lower quadrant of the abdomen.
So a teenager comes into the ER with right lower quadrant pain, fever, nausea. The surgeon on call immediately thinks appendicitis.
They rush the kid to the OR, they go in to take out the appendix, and it looks perfectly normal. But all the lymph nodes around it are huge and inflamed. That is mesenteric adenitis caused by Yersinia enterocolytica.
Last but not least, Pasteurella.
Pasteurella multocida, the rapid biter.
This is the classic dog, or more commonly cat bite infection. It's part of the normal mouth flora of many animals.
The #1 differentiator here is speed. Most wound infections take a couple of days to really get red, swollen, and nasty. Pasteurella causes a rapidly progressive cellulitis, often within 24 hours, sometimes as fast as 4 hours after the bite.
So if a patient says, the cat bit me this morning and now my whole hand is a swollen red balloon, you have to think Pasteurella.
It should be your #1 suspect. It also has a distinctive mousy or musty odor when grown in the lab. And here's the treatment twist. Most animal bites are polymicrobial, so we usually use broad-spectrum drugs like amoxicillin clavulinate. But Pasteurella itself is uniquely, beautifully sensitive to good old-fashioned penicillin G.
It's an old-school bug. It hasn't learned all the modern resistance tricks of the others yet.
Exactly. It's one of the few gram-negative rods that simple penicillin still reliably kills.
Okay, we have survived the island of misfit toys. We've climbed the Andes. We've mowed over rabbit nests, investigated cooling towers, and dodged starving fleas. Let's try to consolidate some of this.
Sounds good. Let's do a quick rapid recall using media matches. I'll say the special agar or stain. You say the bug.
All right. Buffered charcoal yeast extract, or BCYE.
That's Legionella as the primary user, but also Francisella.
Okay, what about Reganlow, the one with charcoal?
Go to telepertussis.
Warthin starry silver stain.
Bartonella, no question.
And a medium that requires cysteine enrichment, like a special chocolate agar.
That's the hallmark of Francisella tularensis.
Perfect. Now let's do our single best answer quiz. I'm going to give you a clinical vignette. Listeners at home, try to answer it in your head before the expert does. Ready?
Ready.
Question 1. A 45-year-old man with advanced HIV presents with several raised purple vascular skin lesions. He mentions he has a pet cat at home. A biopsy is performed. Which cellular finding would most strongly distinguish the likely bacterial cause from a common viral malignancy?
The presence of neutrophils.
Yeah.
This points directly to bacillary angiomatosis caused by Bartonella henselae. The viral mimic, Kaposi sarcoma, would show lymphocytes and spindle cells, not a neutrophilic infiltrate.
Excellent. Question 2. An outbreak of pneumonia occurs in a retirement community following a plumbing repair. Patients present with high fever, confusion, and watery diarrhea. Lab results show significant hyponatremia. What is the key metabolic requirement of the causative organism?
Iron and cysteine. The organism is Legionella pneumophila, which requires these specific nutrients provided by BCYE agar. The clinical triad of pneumonia, confusion, and diarrhea, plus the hyponatremia, is the classic picture.
Very good. Question 3. A 6-month-old infant is brought to the ER with spells of intense coughing that often lead to vomiting. The infant has not yet been fully vaccinated. A CBC shows a white blood cell count of 45,000 with 80% lymphocytes. What is the mechanism of the toxin responsible for this specific hematologic finding?
The mechanism is ADP ribosylation of G proteins. This is Bordetella pertussis. The pertussis toxin disables the inhibitory G protein, which prevents lymphocytes from leaving the bloodstream, causing a massive lymphocytosis.
Exactly. Question 4. A 30-year-old landscaper on Martha's Vineyard presents to a clinic with a high fever and a painful ulcerated lesion on his thumb, accompanied by severe tender axillary lymphadenopathy. He reports clearing brush and mowing tall grass several days prior. What is the most likely pathogen?
That has to be Francisella tularensis. The ulcer glandular presentation is classic, and the lawnmower or landscaping history in an endemic area points directly to contact with an infected rabbit or tick.
Perfect. Question 5. A patient with a prosthetic heart valve develops low-grade fevers and fatigue. Blood cultures are reported as negative at 48 hours. After 10 days of incubation, the lab calls to report growth of a gram-negative rod. The patient had a root canal 3 weeks ago. Which organism is most likely responsible?
This is a classic HACE group organism, most likely Cardiobacterium hominis, given the context of this deep dive. The key clues are the risk factor of a prosthetic valve, the recent dental procedure, and the characteristic slow growth leading to initially negative cultures.
And one more. Question 6. A 15-year-old male presents to the emergency department with significant right lower quadrant pain and fever. An appendectomy is performed, which reveals a normal appendix but markedly enlarged and inflamed mesenteric lymph nodes. A history reveals the family recently adopted a puppy that had diarrhea. Which organism is the most likely cause?
That is a textbook case of pseudoappendicitis caused by Yersinia enterocolitica. The transmission from a puppy with diarrhea is a classic clue, as is the finding of mesenteric adenitis instead of appendicitis.
We covered a tremendous amount of ground today. What's the final big picture takeaway from this eclectic group of bugs?
I think it's the concept of the accidental tourist, with the major exception of Bordetella, which is a uniquely human pathogen. Almost all these organisms live happily somewhere else. Legionella wants to be an amoeba. Brucella wants to be in a goat. Francisella wants the rabbit. Yersinia wants the rat. We are accidental, often dead-end hosts. The severe symptoms we get, the plague buboes, the cytokine storms, the massive anemia, are often just a result of a profound mismatch of evolutionary intent. The bacteria isn't necessarily trying to kill us. It's just confused about where it is, and our immune system panics in response.
That is a very humbling perspective. We are just the collateral damage in a much larger microbial world. That wraps up our deep dive into Murray's Chapter 29. For the students out there, go read the chapter. The details on the toxins and virulence factors are definitely worth a second look.
And maybe don't mow over rabbit nests.
Words to live by. Keep digging deep.